the structure of the normal heart. So we're going to go through the various segments of the hearts. And I don't need to tell you all here because you are all sophisticated investigators in your own right. So we're going to start off with structure of the atriums. We're then going to move to the ventricles, and we're going to finish up with the arterial trunks. And at this stage I should take just a little time out, because I am sure that there are many of you in the room who are upset that I talk about atriums and not atria. And I've recently returned from a meeting of the International Nomenclature Committee in Japan, where I had a most heated argument with a colleague of mine from Italy who insisted that we were bastardizing the Latin language by anglicizing these words. But I tried to point out to him that the whole beauty of the English language is that it has taken words from all sources and has turned them into English. So you will now no longer find us talking in Latin for the various words that have been derived from Latin, but we turn them into English. And you will all now be well aware that no longer is English the lingua franca, but the lingua franca is now American. And our American cousins are somewhat more radical in their changes to the American language than we have been in the English language. So nowadays, if you pick up the New York Times, and increasingly if you pick up the Times of London, you will find descriptions of symposiums. And symposiums tend to take place in hotels which are next to stadiums. And in most of the fancy new hotels that you stay in these days, you find that the hotel rooms are arranged about atriums. So anything that is good enough for the New York Times and the Times of London is good enough for me. So I make no apology whatsoever from Americanizing the Latin words, and I think in the fullness of time, again, it will show its value in syntax and in grammar, because think of the superior vena cava. When the superior vena cava is adjectivalized, which is a terrible new word, but when an adjective is made out of the superior vena cava and we talk about flow through the superior vena cava, you will see people talking about superior vena caval flow. Now, if any of you are grammaticists, you will know that the flow through the superior vena cava is not caval, which is hollow, but is venous. And that is because the word has not been Americanized. Whereas if we talk about the superior caval vein, then we can then talk about superior caval venous flow, which is grammatically correct. And I was discussing this with a very good friend of mine from Holland recently, and he tells me that his young molecular biologists now talk about the right atria and the left atria because they don't realize that atria in fact is a plural word. So I rest my case. And again, I make no apologies whatsoever from Americanizing all these Latin words. And what is even better is that when we Americanize words like truncus arteriosus, we get common arterial trunk, and you don't then need to define it. So I put it to you that if you put all of these words into their American versions, everybody will understand, or at least everybody except the Italians will, apologies there, will understand what we're talking, certain Italians. So that is my party political broadcast on behalf of Americanization of the English language. So let's get down to the nitty-gritty. Because what we're going to talk about over the next days is the need to recognize these various structures on the basis of their most constant component. We're going to come back to that after lunch when we talk about the morphological method. And we'll tell you that the essence of the understanding of congenitally malformed hearts is to recognize structures on the basis of morphology and not of their position. So if we are going to recognize them on the basis of their most constant component, the first thing we need to know is how many components do they have. And when we start looking at the various chambers of the heart, there are some surprising things that come to light. Let's start with looking at the atrial chambers. So, how many components are there in the atriums? And there are the same number of components in the right atrium and in the left atrium. Well, for starters, there is a body of the atrium, much better seen in the left atrium than the right atrium, but not generally well recognized. The venous component, obviously, is well known to one and all. But there is then also a vestibule. And in many places these days, when we talk about the atrial vestibule, people don't know what we're describing. It goes back a very long way, because Wilhelm His, the elder, spoke of a strange thing in the heart, which was called the spina vestibuli, the spine of the vestibule. And you cannot understand what the spine of the vestibule is until you know what the vestibule itself is. And then there is the appendage, crucially important, and finally the septum. So perhaps already I've introduced you to some atrial components of which you were unaware. So as always, pictures are worth thousands of words. So let's look at the structure of the normal right atrium. This is a picture of the right atrium of the normal heart. We've taken it by positioning the camera a little to the right and obliquely behind the atrial chamber. So this is the aorta. This is the pulmonary trunk springing out of the right ventricle. This is the atrioventricular groove. Can everybody understand the picture? I find oftentimes that I show pictures that are immediately obvious to me, and I realize when the questions appear that I'm showing things that are unmistakable, that are unrecognizable by the rest of the room. So hopefully you can see what I'm showing you, and you will appreciate that this is the venous component. Very nicely here you see the superior caval vein coming in at the top, the inferior caval vein coming in at the bottom, and then what you now appreciate is that the entirety of the anterior wall of the right atrium is formed by the appendage. We're going to describe the very characteristic shape of this appendage, which is like the map of India, upside down. And we're also going to talk about this very obvious groove, and this is the terminal groove, or the sulcus terminalis. Now we get an even better position of what's going on when we look inside the right atrium. And this is the cast that Andrew has already shown you. So the internal view, we're going to show it you several occasions during the course. And now beautifully you see these various atrial components. And you see that the venous component here is smooth-walled. And coming into that smooth-walled venous component, we have the superior caval vein, the mouth of the inferior caval vein, since we chopped that off at the diaphragm, and then the third crucial venous tributary, the coronary sinus. You can now beautifully see that the appendage is characterized by its internal aspect of these ridges, and these ridges are the pectinate muscles. They are called the pectinate muscles because they branch out like the teeth of a comb relative to a muscle bundle here, the terminal crest, which marks the internal location of the terminal groove. But now you also note, I hope, that there is this smooth-walled component of the right atrium where the musculature inserts into the atrioventricular junction. Note that the pectinate muscles extend all the way down to the crux, and they separate that smooth-walled venous component from the second smooth-walled component, which is the vestibule right atrium. And then if we look inside the atrium by making a cut parallel to the atrioventricular groove, reflecting away the anterior wall, and now beautifully you see these pectinate muscles, you see them originating from the terminal crest, you see them extending out in parallel fashion, and when you look here at the cut part adjacent to the atrioventricular junction, you see how the pectinate muscles are encircling the orifice of the tricuspid valve. And you then note the smooth venous component, here the coronary sinus, and then the other wall, which you did not see initially because it is posterior. So it was at the back of our cast, and that is the septum, surrounded by the margins of the oval fossa. And once again, hopefully you now appreciate the smooth vestibule. And we're going to be talking quite a lot about this important triangular area on the septal surface of the vestibule, and the tendon of Todaro springs through here and represents Wilhelm Hisse's spine of the vestibule. If we then turn our attention to the left atrium, again externally, we see the appendage, discrete from the venous component. But then when we look internally, again using the cast that Andrew will be demonstrating to you very shortly, we now see all of these components apart from the septum, because the septum again is on the back. We're looking at this cast from the left side, so this in fact is the posterior part of the left heart. The anterior part is on the other side, so you don't see the septum, but what you do see internally is the appendage with the coddle-like small pectinate muscles confined within the appendage. Now on this side you see the body, and we know that there is a body because in totally anomalous pulmonary venous connection it is discrete from the venous component. The veins are coming into the roof of the atrium, but because on the left side the pectinate muscles are confined here within the tubular appendage, the entirety of the cavity of the left atrium apart from that appendage is smooth, so the vestibule is confluent with the smooth body, which in turn is confluent with the venous component. So the same components within the chamber, but a rather different orientation one to the other, most markedly the orientation and the structure of the appendage return. So let's now look at the ventricular mass. How do we describe ventricles? Well, here we take note of their function, because the ventricles are the pumps to the circulations. And if pumps are to work properly, then they have valves and they have pistons. And we can turn that analogy towards the ventricular chambers, and we can appreciate that the piston is the apical component, and guarding that apical component and permitting it to function so as to drive the blood through the circulations, we have inlet and outlet valves. In other words, just as Caesar described Gaul, so we will describe ventricles in tripartite fashion. Gallus tres part something est. Gallus tres pars divida est. I think that is the appropriate phrase, is it not? The opening words of Caesar's Gallic Wars. So now, ventricles tres pars divida est. So as we apply our tripartite analysis to the ventricle, and let me emphasize that we consider the ventricular mass as extending from the atrioventricular junction, which you see as a discrete entity, to the ventricular arterial junction. We'll talk about the ventricular arterial junction after you've had your coffee break. It's a little more complex, but nonetheless, when I show you this picture of the normal right ventricle having removed its parietal wall, then what you can see is that there is an inlet extending from the atrioventricular junction to the attachments of the papillary muscles of the tricuspid valve. There is an apical trabecular component, which in the right ventricle is coarse, and then there is a smooth, completely muscular outlet leading up and supporting the leaflets of the pulmonary valve. And then, when I turn my attention to the left ventricle, again defining the left ventricle is extending from the atrioventricular junction to the ventricular arterial junction without question. we have these three components: the inlet extending from atrioventricular junction to the attachments of the papillary muscles, the apical trabecular component, which in the left ventricle is fine and crisscrossing, and then the outlet, abbreviated because the posterior part is no longer muscular. The roof of the left ventricle is formed by fibrous continuity between the leaflets of the aortic and mitral valves, but despite that, an obvious outlet component, which we will describe later, supporting the leaflets of the aortic valve. So ventricular description is done on the basis of these three parts, and as we will show you, this tripartite approach to analysis permits us to describe all ventricles, be they normally formed or be they congenitally malformed. One thing I should introduce at this time, and perhaps it's the hardest concept to take on board, and that is the concept of ventricular topology. And it is a fact that whenever you find a morphologically right ventricle, somewhere within the heart you will find the remnants of the left ventricle. So always right and left ventricles coexist. They don't always coexist in normal fashion, but they are always there. And because of this, they have fixed relationships to each other. And it is these relationships to each other which we describe in terms of topology, because you cannot rearrange topology unless you cut the parts aside from one another and stitch them or glue them together in different fashion. And there are only two topological patterns. They are mirror images of each other, and we liken them to the hands, because the hands, of course, are the exemplars of Strauss mirror imaged. And we describe ventricular topology according to the way that the palmar surfaces of the hands can be placed upon the septal surface of the morphologically right ventricle, and by convention we take the right ventricle. We could easily well have taken the left ventricle, but we didn't. It is convention that we describe ventricular topology according to the right ventricle, and it depends upon the way that the palmar surface of the hand fits on the septal surface of the ventricle, such that the thumb goes in the inlet and the fingers in the outlet. And when you look at this right ventricle from a normal heart, you will appreciate that it is only the right hand that fits upon the septal surface of the normal right ventricle. Anybody who can get their left hand on the picture you see on the board at the moment, please show me your left hand afterwards, because it will be a very strange left hand. And no matter how we twisted this ventricular mass, it would still only be possible to get the right hand on the septal surface, making this right hand topology. Now this is the ventricular mass from a patient who has congenitally corrected transposition. And later in our course we're going to show you congenitally corrected transposition. So here is the tricuspid valve. This happens to be the aorta, but it doesn't matter, it's the ventricular outlet. And I hope you will all now see that the only hand that will go on the septal surface of this ventricle is the left hand, because the essence of congenitally corrected transposition is that there is mirror imagery of the ventricular mass in the setting of usual atrial arrangement. And again, no matter how you turn this ventricle, you will only ever get your left hand on the septal surface, with the thumb in the tricuspid valve and the fingers up the outlet. So that is left hand topology. There are certain circumstances when you can't work out topology, when there is double inlet ventricle, and that is because in the setting of double inlet ventricle you cannot anchor your hand in the incomplete right ventricle. But apart from that, all hearts can be described when they have two ventricles in terms of right hand and left hand ventricular topology, and that is the convention we'll use through the rest of the course. Finally, the arterial trunks. much easier to describe. You will all immediately recognize the cartoon on the board at the moment as the aorta, and you know that this is the aorta because it gives rise not only to the coronary arteries but also to the brachiocephalic arteries. And you will all immediately recognize, I hope, that this is the pulmonary circulation. Now, all the time I see people describing the main pulmonary artery. In fact, the appropriate way for describing the confluent part of this circulation is the pulmonary trunk. And so the pulmonary trunk divides into the right and the left pulmonary arteries. And so here is a picture of the normal arterial segment. You see the aorta, you can't see the coronary arteries, but you can see that it gives rise to the brachiocephalic artery. Why on earth should we want to call this the innominate artery? What does innominate mean? It means unnamed. So why would we want to call something the unnamed artery when we can call it the brachiocephalic artery? Because it gives rise to one artery that goes to the arm, the brachium, and the other artery that goes to the head, and I forget what the Latin word for head is, but it is the brachiocephalic artery. And then we have the left common carotid artery and the left subclavian artery arising from the arch. Then we have pulmonary trunk divided